So thank you very much for joining us today for our, I'm actually lost track. I think it's maybe the 7th in our series of webinars. Much appreciated that you're joining today. As usual, we are going to start with the land acknowledgement before we move into the remainder of the webinar. So Jerry, if you advance the slide, we will start to acknowledge. While we meet virtually, let us begin by acknowledging the ancestral territory of all the First Nations, Inuit and Métis peoples from coast to coast to coast upon which we meet today. We acknowledge the need to work collectively and individually to recognize the past and continued effects of colonialism, racism on Indigenous families, communities, and knowledge systems through the Indian Act, Indian residential schools, Indian hospitals, and other systemically discriminating policies, practices, and documentation. We affirm our responsibilities as settlers to improve relationships between nations and actively seek greater understanding of Indigenous peoples and cultures in the communities in which we live, learn, work, and play. Please join us in this acknowledgement and commitment, each in our own way, through teen primary care, and to move forward through truth and reconciliation. Today's webinar addresses equity, diversity, and inclusion in the workplace among colleagues. We have an amazing lineup for you today, starting with some presentations and followed by a panel. But we want to acknowledge that while we're focusing on EDIA within the workplace among colleagues, we are also operating in the context of broader issues with our patients, communities, and the world around us, including those who are suffering from the most recent and ongoing conflicts that we are acutely aware of today as we sit here and think about the current situation in Israel, Palestine, and Afghanistan. We also want to acknowledge those who are experiencing the effects of natural disasters. So now that we move into the first part of our webinar, we are going to hear from 3 individuals, many of you know, who will talk about various aspects of equity, diversity, and inclusion in the workplace among colleagues. The first speaker is Jerry Maniate. He's a physician at the Ottawa Hospital, an educator at the University of Ottawa, and a researcher at the Bruyere Research Institute of the Ottawa Hospital Research Institute and the University of Ottawa Music and Health Research Institute. He has extensive leadership experience in higher education, working with health professionals, health systems, and national medical organizations. He's the former vice president of diversity, inclusion, and education at the Ottawa Hospital and is the founding director and investigator of the Equity and Health Systems Lab, what many of you know as EQHS. His work focuses on understanding and addressing inequities in health systems through collaborative partnerships. So a very busy individual, as you all know. Stella Ng is our additional speaker. She's the director of the University of Toronto's Centre for Advancing Collaborative Healthcare and Education. CASH, many of you know it by CASH. Prior to that, she was the director of research and co-developed the Teaching for Transformation program at the University of Toronto's Centre for Faculty Development at St. Michael's Hospital. She's passionate about the transformative potential of education, particularly critical reflection and pedagogies to foster collaborative, compassionate, and ethical healthcare and health sciences. This passion was sparked by challenges experienced as an audiologist in the public school system and motivated her to complete a PhD on how people learn and practice in the face of value conflict and uncertainty. She is also an associate professor in the Department of Speech Language Pathology and the Institute of Health Policy Management and Evaluation, and is a Wilson Center scientist. I want to put in a plug to make some of these institutes' names a little bit shorter so I can get my tongue around them all. Our third speaker is Cameron Moser. Since immigrating to Canada 15 years ago, he has supported thousands of other immigrants in achieving their professional goals. As the Senior Director of Services and Program Development at Access Employment, Cam is responsible for the services that support internationally educated healthcare professionals in putting their skills to use in the broader health sector. At the foundation of these services is a strong belief that improving internationally educated healthcare professionals' access to high-quality employment opportunities is a critical part of building a more equitable and inclusive health system that Canadians need to live a happier, healthier, and more fulfilling lives. Over to you, Jerry.
Thanks very much, Dale, and welcome to everyone who's participating with the webinar. It really is indeed our pleasure to have you join us in this dialogue, and really look forward to hearing from you as we engage in our discussion this afternoon. One of the things that we wanted to start off with was just to highlight that some of the topics, because of the nature of what we're talking about, may make you feel uncomfortable, but we certainly don't want you to be positionally moving into the unsafe space. Uncomfortable helps us stretch ourselves, push ourselves, challenge ourselves, helps disrupt how we think, while unsafe threatens and restricts and impedes our willingness to participate. So we acknowledge that today may be a situation, compared to maybe some of the other conversations you've had, may make you feel uncomfortable, but certainly if it feels unsafe, please reach out, let us know, so that we can learn from the experience ourselves, as we want to continue to role model that behavior as well with you. So one of the pieces that we wanted to create was this concept of a brave space, a space where we're going to allow for each other to speak for ourselves, with no real pressure to represent or explain a whole group, that we're going to commit to listening with resilience, hanging in when there's something that's hard to hear. That's that stretching sort of feeling that you get. And I always think, you know, when you go to the gym, you want to walk away with that healthy burn, but not the pain that's causing you to have to go seek medical attention. There's a subtle difference. But that burn helps you feel that you're actually stretching yourself, pushing yourself into a space. And perhaps cognitively, we'll get a little bit of that healthy burn with our conversation today. We want you to avoid, even if you feel tempted to make attributions about beliefs of others. Instead, ask questions. Try and understand the assumptions that maybe have been made or maybe underpinning what was said. Focus on impact over intention. Most people, unless they can get in my head, and maybe the only people that can do that are my wife and my kids, they may sort of understand what might be underpinning why I say certain things. And so let's focus in on understanding that that intention piece might not come out, but rather we need to focus in on the impact and interrogate and push and help each other stay accountable with the work that we're doing. We also want you to focus on keeping the stories here. Share the ideas, but keep the stories. The stories may be personal. The stories highlight the safe space that perhaps we're trying to create here. But but unless they are your own stories, we would encourage you to keep them here. So our outline for today, we want to actually do a little bit of setting the stage with a little bit of background from Stella, Cameron, and myself. And then we're going to have a panel discussion where we're going to explore some questions. We're going to engage you as an audience as well with that. So be prepared to participate, because that'll be very important to stimulating the discussion. And then we'll head into a bit of a summary before we close up the hour. And so with that, setting the stage, I'm going to hand it over to Stella to lead us through the next part.
Thank you so much, Jerry. And I'll try to keep it quick because I'm most interested in hearing from the rest of you and our panel.
Sorry, Stella, I think this is the one part that I was supposed to do still.
Oh, okay.
And then I'm going to get to you in the background.
No
Sorry, my apologies. So I wanted to show a very quick video because I think this will help get us all into that right headspace. And then Stella's comments will really make sense. But this is a video, and we want you to just look at it, watch it, see what's going on, and more importantly, are there lessons that we can extrapolate into the health sector? And so feel free to use the chat to put some of your comments and thoughts down. Very short video. But what was going on there? And I think more importantly, what was being permitted to occur? Are there any thoughts? If you want to put up your hand or put something in the chat, please feel free to do so. Unsafe work environment, yes. Appearance more important than care. Teresa, I don't know if you wanted to elaborate a little bit more about that, and then I'll come to Amy again.
Turn on the mic, I'll elaborate quickly. They maintained the musicians there and the others in the line maintained their position as if looking good was more important than caring for the person beside them who's just collapsed.
Yeah, the show must go on, right?
It must go on, yeah.
Yeah, the co-workers kept working. Amy, you had mentioned unsafe work environment. Do you want to elaborate a little bit more on that?
Yeah, it's clear that he's actually not the only one that's collapsing under the heat, and there really doesn't seem to be any indication from those who are orchestrating or perhaps the leaders or those who are in positions of power who are having expectations of this event that there's anything going wrong, right? It's just you just kind of keep moving with it. That was really hard to watch, actually.
It is. It's tough because you almost feel the pain of what's going on. Did you see the person that was in front, the person with the baton, the yellow outfit, completely unaware of what was happening behind them, right? And yes, Katie, surprised he went back to trying to play this individual, whoever it was. Wow. And then others seeing but not addressing. I loved it when the gurney came, or the stretcher came around. The person just basically said, "It's that person right there." They hadn't really stepped in and done anything else, but they were at least pointing. They acknowledged that they had seen what had happened in doing so. So it's interesting. Like this is a particular video. It was 30 degrees out, wool tunics and bearskin hats. And this is what was going on. So can we apply any of this to what we see in our health system? Do we experience or see or witness any of this happening in our system today? All right, I see a few people making some head nods, the ones that I can see on my screen here. And I think this resonates with a lot of people, unfortunately, that what the story is here. Yeah, no bathroom breaks, nutrition, people's needs being ignored. So these are some important things. Let's park that in the back of our mind. And then I'm going to hand things over to Stella in a second as we look at this. What we permit, we promote. What we allow, we approve. What you don't condemn, you condone. And framing this is really important as we talk about equity, as we talk about accessibility, as we talk about social justice and diversity and inclusion. All these concepts resonate with these statements here. So I'm going to pass things over to Stella, and she'll lead us into our next section.
Thank you so much, Jerry. So I will go quickly because we're interested in really diving deep with our panel, and our purpose, Jerry, Cameron, and I, is to sort of give some background as to why we've invited this group together and why these conversations with Equity, our Access group, as well as CASH coming together for this webinar. So in healthcare, speaking from the Center for Advancing Collaborative Healthcare and Education, we often talk about equity as a target for health workers to address within and for communities and patients. So often physicians, nurses, other practitioners will be directing this equity work outward towards patients and communities. And this is great, yet we also need to build that support within teams and within healthcare culture itself. So an example of this is at CASH, we've started to ask questions inspired by the work of people like Sarah Wright, who's here in the room. Do we invite diverse identities into our teams to conform people to our norms, or do we actually invite folks in and welcome them to bring their diversity into the ways in which we work? Or another way of saying this, are we willing to change our culture and practices in addition to getting people to work the way that we work? In air quotes there. A reminder that a strength of the interprofessional education and interprofessional collaboration fields has always been not only to address quality and safety and care, to mitigate gaps between communication. Also, IPE and IPC arose to mitigate unhelpful hierarchies between professions that can get in the way of optimal care. So you'll notice that our center's naming, this happened recently, has changed. So we emphasize collaborative healthcare, because by saying interprofessional, which is still important, we're not being inclusive of folks like support workers, environmental services workers, family caregivers, community members, patients and clients themselves. And you'll see on the next slide that the Canadian Interprofessional Health Collaborative has actually changed a lot of their wording in their competency framework to align with this, where we're moving from patient services, patient-centered care to collaborative relationship-focused care, from interprofessional communication to team communication, interprofessional role clarification to role clarification and negotiation. And an interesting change, interprofessional conflict resolution, as if all conflicts can be resolved, to team disagreements processing. Like, let's sit with this, sit with the difference. Maybe there's something good in that difference. So it's important for us to keep in mind, and I'll transition to Jerry with this, that while all our experiences and perspectives are important as different professions, different worker groups, our identities as professionals are not neatly compartmentalized from our personal identities. So we look forward to hearing from our panelists some of these complex intersections between our roles, experiences, and identities, and how we can build together for a more equitable and collaborative care system. Over to you, Jerry.
Thanks very much, Stella. And as we take what Stella was talking about CASH and the expertise that they're building and supporting, one of the things that we wanted to highlight was just some of the areas that the Equity and Health Systems Lab can support work that you might be thinking about in your local context. How do we build belonging into where we find ourselves? And part of the problem is that we're dealing with a lot of societal challenges, right? The concepts of isms and phobias might be something that you may hear, and we might say, "Oh, that's really happening out in the community. That's in society around us." But the teams that we work with are representative of the communities that we find ourselves within, and so people bring the isms and the phobias into these spaces. And they may be hidden, they may be masked, but they're still underneath the surface. And so sometimes we need to explore, we need to expose and support people as they move through this. And so with this, how do we create this sense of belonging? Well, first of all, it takes time, it takes intentionality. And it's not something that happens, as I say, instantaneously. You have to actually build pieces into the space. That start with the absence of certain things like ableism, harassment, and sexual violence and racism, but you have to move into creating that psychologically safe space, actively welcoming and engaging others, to finally getting towards a sense of belonging. But this takes, as you can see, these two rails, this continuum of inclusion and belonging, and also lifelong learning and humility. as we know, psychological safety is critical to having teams function. We know that this is really important for creating the inclusion, diversity, but also performance. And so we know there's a practical side of, so if you're a leader in an organization, there is a real importance for ensuring that your teams have psychological safety from a performance perspective. But from a care and an experience perspective, it's critical as well for the patients and the clients and the families, but also those that are working within. This quote, this tweet came out a couple of days ago, but culture is like a pickle jar. You can't blame a perfectly good cucumber for turning into a bad pickle. You must examine the brine they're in. Culture matters a lot. And I think most of the time we focus on the cucumber. And very rarely do we actually explore what's happening in the environment that the individual and individuals in the team are finding themselves within. These are really good people that have chosen to come into the health profession and into the health system. So how do we approach this? How do we dissect this through? Well, our approach in the Equity and Health Systems Lab is foundationally based in humility, driving into curiosity, asking those questions sincerely, with the purposeful listening so that we can understand, reflect, and then intentionally unlearn, relearn, and move into partnership. This kind of process doesn't happen instantaneously either. It starts from an individual perspective and requires the team as well. So how do we build relationships and trust? Well, if trust is the fundamental underpinning problem, or the lack of trust or the mistrust that's happening, we need to find ways to collaborate and create those opportunities where trust can be rebuilt through relationships. And this kind of process can be and should be guided through that kind of space, because it can be tough, especially when we're unpacking things such as equity and accessibility challenges. And so that's what we're trying to do with our lab, and trying to support team primary care initiatives through this process. And we want to come alongside and partner and learn in your context and bring this content into your spaces. So if you have questions, definitely would be easy to reach and get a hold of as we move ahead into the rest of our discussion. But I'm going to hand it over to Cameron, and he's going to provide a little bit of an overview of Acces and some of the work that they are doing as well.
Thank you so much, Jerry. I really appreciate it. And I'll just give you a little next, I guess, when we go through the slides. But Acces Employment is a large settlement services and employment services organization, physically based in the GTA, but with services all around Canada and really serving people around the world, whose vision is a fully inclusive labor force that reflects the diversity, skills, and experience of Canada's population. And our, small contribution in this huge team primary care initiative is to really bring the skills of internationally educated healthcare professionals front and center. Can you go next, Jerry? And the question that I wanted to pose in today's webinar and for all of us here is, how might actively applying equity, diversity, inclusion, and access frameworks in the hiring, licensure perhaps, of internationally educated healthcare professionals improve equitable access to care for recent immigrants? And I phrased that way very specifically because equitable access to care affects, millions of Canadians. And there's a, much larger effect, much larger inequity when we come to individuals who have just recently arrived in Canada. Next slide, Jerry. And that's, when we look at the numbers for many of us who aren't in the world of immigration or who don't pay attention to that trend are, they're really significant. So in 2022, there were almost 440,000 new permanent residents in Canada. And at that time, there were over 600,000 temporary residents also living in Canada. So the rate of population growth in Canada is, being rapidly driven through immigration processes. And these are the patients across wide swaths of Canada that are coming in and seeking equitable access to care. Next, Jay. For recent immigrants, they're much less likely to have a regular healthcare provider than native-born Canadians, and also much less likely to have a regular healthcare provider than individual immigrants who have been in Canada for a longer period of time. And many of them face linguistic barriers, cultural barriers, and systemic barriers to being able to access the kind of care that they need to start a new life in Canada. Next slide. The work that we do with internationally educated healthcare professionals, so internationally trained physicians, pharmacists, dentists, nurses, really mirrors some of those inequities. So the healthcare professionals who were in those groups of immigrants, they face those barriers themselves, with barriers to licensure, while also still being very able to contribute in meaningful ways, and wanting to contribute to providing appropriate care in appropriate ways. And we have really, through our work in team primary care, used equity, diversity, and inclusion and access principles to create more inclusive training, and to help the employers that we work with, the wide range of employers in the health sector, to create more inclusive workplaces so that internationally educated healthcare professionals can be a part of the answer in creating more equitable care. Next slide, Jay. And so I'm just going to go through, I know we're pressed for time, just really quickly here, but some things that I'd like us all to think about are, the ways that our hiring practices could be made more inclusive. And it strikes me when we were talking with this with one of our participants who was an internationally trained physician from Afghanistan who had run HIV/AIDS prevention community health initiatives across Afghanistan during the war. We were discussing these kind of issues, and he said, Cameron, all of the things that we can do to make hiring more inclusive and more effective for immigrants makes hiring more inclusive and more effective for everybody, right? So effective, clear job postings, skills-based hiring, honest sharing about what jobs really are and what they look like and what they require. Next slide. And then in the workplace, working on really clear and direct communications, on recognizing how much of our communications rest upon implicit knowledge. And I say our communications because that's everyone around the entire world. When we communicate, we work so hard as professionals to remove those implicit barriers to how we're communicating. And that makes a big difference when individuals are looking for work and looking to succeed in the workplace. Because I think we're all, in the same space where we want to create open and even playing fields, where individual skills are able to come to the forefront, and where when they are in the workplace, there's opportunities for regular feedback and further communication through individual connections, through team-based supports, and through other ways that make sure that the healthcare environments that we're creating create opportunities to give the most effective and care for the individuals we're serving. Next slide. And all of this great work that we're doing is funded by a lot of people who share some pretty amazing goals with us. And we're really looking forward to sharing more on this and talking more with you about this as we move into the next part of the panel. So I'll go ahead and I'll turn it over to Dale there. And Dale, you take us into the panel discussion.
Thanks, Cam. So we have three amazing panelists who will engage with us and respond to some questions, your questions and others. And so I'm just going to introduce them before we move on to the panel component of this webinar. The first panelist is Ritika Goel, who's a family physician and assistant professor at the St. Michael's Hospital Academic Family Health Team in Toronto. And she serves as a social justice, anti-oppression, and advocacy theme lead for the MD program and postgraduate medical education program at the University of Toronto. Her clinical work focuses on serving marginalized communities, including unhoused people, people who use drugs, people with severe mental illness, and trans and non-binary people. Ritika has been a part of various social justice movements and initiatives and is passionate about bringing a community and social justice-oriented lens to medical education and clinical practice. Our next speaker is Sophia Ikura, the founder and executive director of the Health Commons Solutions Lab. She launched the Health Commons to support the building of practical solutions to address health disparities, working with a range of partners to co-design solutions built on the community's knowledge and expertise. Prior to this, Sophia was the Senior Director of Strategy and Community Engagement for Health Services Planning in Toronto, and she served as Senior Policy Advisor to 3 Ministers of Health and as Senior Health Advisor to the Premier of Ontario. Our third panelist is Vela Tadic. She is the Executive Director for the Briere Academic Family Health Team. Previously, she worked in social services for more than 20 years as a social worker and clinical educator as part of the behavioral medicine family medicine curriculum with the Briere Academic Family Health Team. Vela humbly does not identify herself as an expert in this area, but is committed to social impact throughout her career and a lifelong journey to learning, who, with 2 teenage boys, remind her regularly how little she knows. Jerry, over to you as the moderator.
Thanks, Dale, and thank you to our panelists for joining us in this conversation. What we wanted to do was to start off with actually a question that we wanted to pose the audience. And so I'm going to go to our next slide here. And if you are able to, join us by the web, thepolev.com/EQHSlab530, or you can scan the QR code at the top right-hand corner. And we have a few questions that we're going to be using here. But our first question is, what can our training programs aspire to when moving towards interprofessional team-based care? And Katie says that she can't see the QR code. I'm going to type in the link into just oh, sorry, I typed that incorrectly. There we go. That will be better. Actually going to see if is it not working? Technology. Up. It's working. Okay, good. I'm just trying to see if it's showing up here.
Sherry, just a question of clarification while you're working on the technical aspect of it. Are you speaking specifically about training programs for health professionals, or are we talking about really any training around the integration of people into different work environments and also the training of health professionals, just so that I can orient myself on the question?
I think we can leave it open to either, because both of those end up into the same environment, right?
Sure.
So there's a lot of overlap in that kind of space. So I think we can explore both. I'm going to try and go back to my slide here. See why it's not open. Apologize for that. thought it was going to be working there. Okay, we're starting to get something. A couple of ideas. Thank you. The technology is working now. Practice humility, awareness, practice, practical, I assume. True consideration, discussion of each person's contribution, and focus on really helping people to take a step back in their communications, understand the situation at hand, getting clarification, inclusive for all members. Okay. Be prepared to the community needs. Aspire to be inclusive, other providers and their roles. Nice, nice. I'm sure others are going to be coming through. Sophia, Ritika, Vela, are there any thoughts as you see this question from your experiences and different vantage points? What would you say are some of the critical things? Maybe I see Sophia is on the screen here, so I'm gonna maybe throw it over to you, and we'll start with you.
I mean, I think it's a really broad question, so I can speak to it from two perspectives. I think that as we think about how do we create a healthcare system that is more responsive and providing more a fairer and more effective access for all communities, I think about a transformation that needs to happen kind of at two levels. One is, how do we ensure that the workforce itself includes representation from many different groups and many different experiences? Because representation, there's really no, I don't think that there's any better opportunity to understand first what the challenges look like and also what the opportunities might be to resolve those. And so because equity is a very hyper-local experience, what's available to you in terms of solutions has to come directly from the ground, and having people who I think intuitively understand the experience, but also how to enter into conversation with communities where we can better understand what that looks like, really contribute meaningfully to a rich set of solutions in that space. And so anything that allows for us on the training side of the house to really open up our minds to what expertise looks like and where expertise lives. So our systems are largely built around experts come from these spaces, and this is what they look like. Training that really opens people up to this idea that there are a broad range of expertise that we need to be tapping if we want to get to a fair and more equitable system. But then I also think training that in some ways really begins to think about how do we build teams that can work effectively. So diversity builds huge bench strength in workplaces, but it's also challenging to manage because there's a lot of implicit norms and cultural behaviors and knowledge that we are often in the space that we're marinating in, that brine that we're marinating in. And making that much more visible is important. Thinking about as a practice in our training programs, more consistently locating who you are as a worker, but also as a member of a community, and how your positionality really shapes what you bring and what you know, and how it might be different for others on your team are some of the first steps to really getting to effective communication. So there's some just early thoughts.
Awesome, thank you. Vela, maybe I'll come to you. You've had some experience, especially with your background. Where have you seen some of these kind of tensions that we were hearing from Sophia?
Yeah, absolutely. So I think one of the key things that Stella alluded to is the power dynamics, particularly in training. So we talk about creating space, but it really becomes challenged when you have learners who are constantly evaluated. And what is their pathway to speak that voice or talk about their experiences, whether it be with patients or among colleagues. So I know personally, having talked to residents as an example, where they've had encounters, and although there's this awareness and knowledge, who can they talk to? How do they navigate that issue? And if we don't name it, we don't invite that discussion to come forward. And then among colleagues, we have to remember that people come from varying backgrounds of knowledge and expertise as well. And then how do we support that learning in a workplace? Because it is dynamic. So staff come and go, and it's that platform for healthcare providers who are training in those environments. So it's very dynamic and, as you mentioned, quite intentional.
Thank you. So intentionality is something that, and I love the fact you were bringing out the power dynamics, because yes, that can happen within a training program, but these training programs are not, they're running in parallel, but oftentimes they have intersection points as well. Ritika, I know that you've been involved with things at the University of Toronto in the Temerty faculty there. Are these factors that you think about when you're trying to intentionally create these opportunities for your learners?
Yeah, definitely. I think building on what's been said, there's been a lot of work done at U of T to look, for example, at creating a Black student admission pathway, really recognizing the hyper-minoritization of Black people in medicine, particularly as a profession. And we know that it goes back to historic power structures and institutional anti-Black racism. Similarly, we see a hyper-minoritization of Indigenous peoples in careers like medicine. And we know that also dates back to things like the Indian Act that would actually take away someone's Indian status if they were to become a professional like a doctor or a lawyer, or even obtain an undergraduate degree. So I think, I love the image of the pickle and the brine. I haven't seen that specific analogy before, but I think one of the things that I see healthcare institutions and academic institutions struggling with right now, when we're talking a little bit more about equity more openly, as we should, is how to have these conversations in a way that we name that healthcare and medicine and the other professions really are a microcosm of society. Right. So structural racism, structural sexism, homophobia, patriarchy, these things exist in medicine, in healthcare. And I think we struggle with that because we often see ourselves as places where people go into these professions to help people. And, sometimes the approach is one where we sort of, in our intention to say that we support everyone, we can sometimes respond by saying this is a place that does not tolerate X, Y, and Z, and that doesn't always lend itself to open kind of communication around how, in fact, these power structures do play out day to day, and they play out day to day everywhere, because we are all the cucumbers. And so that's the approach really, I think, needs to shift towards one where we can say, we are all struggling with this. We need to be struggling with it together. It needs to be open, and we need to talk about it. The other thing, just building on what Sophia was saying around representation, I think we need representation among our providers, but we also need representation among leadership. Certainly, I can speak to in medicine that we see that among women. There's been a significant shift towards there being more women in the profession and more racialized people in the profession, but we don't see that reflected as much as you go higher up in leadership. And so much of that is structural in terms of you can't be what you can't see. So not having people in those positions, but also in terms of mentorship, there are huge issues of people not being able to access mentorship because there's a difference there in terms of who's in positions of power and who could be.
Those are very important points there, Ritika. And I was sort of wrestling with this because as all of you were speaking, one of the things that I struggle with is that we do things often in the training kind of environment, right? Those formalized curriculum activities, and then we throw them into the clinical space. And I'm putting my previous healthcare leadership kind of role hat back on, and I realize that there's often a disconnect. Those two areas don't often talk. And so whatever is talked about here completely gets undone when they walk into the elevator and hear a comment. Right? So 3 hours, amazing curriculum or whatever gets built, completely gets destroyed within minutes of people seeing what reality looks like. Unless you can find high functioning teams that really embrace collaboration and care. When you put people in that, it reinforces and then pushes people an interesting kind of space. But where do you find those teams? How do you purposely integrate? How do you multiply those kind of teams so that there are more options for learners to engage with? Sophia?
Yeah, I mean, I think it's a bit of a two-stepper. So, you know, I think that there is something that we need to be doing in a paradigm shift in our minds about the way we think about the integration of newcomers and immigrants into our workforce, right? So, you know, I'm saying this having spent 5 years in the Health Human Resources Strategy Division in the Ministry of Health in Ontario. We think about most of our programs for integrating internationally educated as making space for. We don't really embrace the idea that there is incredible expertise coming into our country because we don't have good ways of revealing what that expertise looks like. You know, creating really good matches between those experiences that people bring and the problems that we have in our system. So, you know, recently in the last couple of weeks, we at the Health Common Solutions Lab have been working on just test piloting what would it look like if we had a good pool of internationally educated health professionals that have been vetted by Access Employment. And we gave them 5 days worth of training. And what does it look like working in the healthcare system? How do we, as a lab, tackle creating new solutions around building a more equitable system? What does it look like working in an Ontario context? And at the end of that, created the opportunity for interviews so people could apply for. So they had a really good sense of what the lab was about and how we work and what we're looking for. And what came out of the interviews was extraordinary. You know, I think Cameron spoke about one who built the first gay man's HIV and AIDS treatment program in Afghanistan at a time when homosexuality is considered a criminal act. Another candidate who's an internationally medical graduate who built an immunization program, you know, across 4 states in Nigeria, where they had to plan around insurgency violence in order to be able to address access. So the lab right now is actively working on low immunization rates of childhood vaccinations. This candidate that brings in this incredible experience of design and implementation in Nigeria is a huge asset. And it would have been very difficult to uncover that skill set without the robustness of that training program. So there's an identification of the huge benefit that we get if we do a better job of integrating the skills and experiences of newcomers coming to Canada. And then there's this other piece of it, which is, I think everybody spoke about it a little bit, what changes need to happen inside of our own teams and the way that we communicate with each other. What are those hard skills? They're different from the clinical skills, but equally critical because they are the things that are going to equip us to navigate complex and dynamic conversations. So I have a team member here at the lab whose family came as Palestinian refugees when their family was ejected from Haifa. And I myself have Jewish children, a Jewish partner. And in this moment of having those two identities being in the same space, we have a lot of complex conversations to navigate. There's skill sets that come with that. There's modeling that can come with that. Those are new things that we're grappling with that we need to build. And I don't have all the answers, but I certainly know what it feels like to be steeped in that brine.
So Sophia, with that comment that you gave there, I want us to go to our next question. We only have a few moments, but I wanted to pose it up there because I think it'll stimulate some of this kind of conversation as well. What do you hear from colleagues, care professionals, and or the public when discussions about interprofessional team-based training arise? And maybe this might, and I would love to see, you know, individuals respond into our poll there. And so maybe I'll turn over to, as we're seeing things come up, maybe I'll go to Ritika and then I'll go to Vela just for your initial thoughts on this question.
Sure, I can speak from the perspective of being involved in the medical school and the interprofessional education that all medical students and all other health professional students engage in together at U of T. So I think there are a lot of challenges that need to be addressed and thought about. I think sometimes being able to set up scenarios in which the learners can see themselves as, see this as an opportunity of really kind of practicing what it means to work in a team, and normalizing the idea of working in teams, as opposed to the large majority of education, I think, which focuses on the practitioner in their own specific role. So I think more interprofessional education, I think also using interprofessional education to tackle some of these more complex issues like equity, social justice, anti-oppression, et cetera, because we have to think about, as you laid out at the beginning, not just the power dynamics between providers and patients, but also the hierarchies and the power dynamics within teams. And those are really challenging things to discuss with learners. But you know, you need good facilitation, and you need to create the space to have those conversations now, so that, you know, we can build those teams that you're looking for, those highly functional collaborative teams. But I don't think that shying away from the power dynamics and shying away from the hierarchies is the way to do that. I think, again, we have to examine the brine, name the brine, you know, shine a light on the brine, et cetera, so that we can actually move forward in the conversation. But it obviously has to be done with a lot of care.
Great comments there, Ritika. Vela, I'll give you sort of a last comments here for this question.
Sure. So I think first and foremost, there's a consensus around this is required and important. But how we get there is highly emotional among many, many people. And there's a sense of urgency of doing this yesterday. And I think that's partly healthcare too. I think we like to fix things in action. But as you indicated early on, it's a process. And it goes back to creating the space and the language, the shared language with which we can speak to these things. And really being careful about assumptions that we also are all well-informed, or that once you're well-informed, you're done. And there's no more learning to be had. So I think when we talk about collaborative healthcare training, conflict and the ability to navigate conflict is a big one, because partly we want things to work really well as a team. So there's a surface collaboration versus really taking the time to understand the values base that each professional will often come to, and really valuing everyone's voice. And that's an active dynamic thing as well.
Awesome, Bella. Thank you very much. The three of you just highlighted a lot of the complexity of this. This is messy. It's important, but it's messy. And I think part of this is that there's still this, you know, keeping sort of hands around sort of a semblance of control and power and hierarchy that we talk about, but are we willing to actually open the arms up and share the ideas and share the space and share the opportunity? And so that might be, we're clearly not going to get to the answer at the end of this, but I think these are the kind of questions that we may have to stimulate ourselves to think more broadly as we move ahead. Yeah, check in with both the and the jar. That's right, the container itself might be a problem too. Well, thank you very much. Time has flown by very quickly. We don't have time for, actually, we had one more question, but and I recognize we're getting to the top of the hour. And so we just wanted to highlight a couple of key just take-home points for us to consider, and hopefully you'll have these locked away in the back of your mind as we keep moving into other conversations over the next number of months. But the first one that I wanted to just highlight was just isms and phobias are present. The question is, how do we unpack these in the context that we find ourselves in that health system? How do we create space for these conversations about these areas? I think the other thing that I really gathered as we were having these kind of conversations is that there has to be some authenticity to the individuals involved with these conversations. I think people still come with a mask and sort of a persona that they want to portray, and as a result, we don't get this positionality of humility and curiosity and listening that actually wants us to engage in a conversation of how do we find a solution, how do we move forward, and we may actually need to call out the fact that a lot of this is pride centered and personality centered, as opposed to truly looking at the person who is needing the care and who's at the center. I think the other piece is that education alone is not enough. You know, we can create all the training programs we want. The Brian example, I think, is really sticking with a lot of people. We have to actually do multiple other things. And Ivy, you put in there a comment as well, and about the structures. This is policy stuff. This is process and governance. How do we arrange ourselves? I think really speaks to what we value, and we expect teams to work together. I commonly see this in medicine. I say we have two teams looking after a patient. We have, quote, the medical team, and then we have everyone else. And then we magically talk for 10 minutes and we solve the problems of the world for these patients. And I was like, this doesn't work. The model inherently is wrong, but that's the model that has been in place for decades. And nobody's willing to actually change it. They want to actually change process, little things on the deck chairs on the Titanic, but they don't want to actually address the fact that the ship is going down. And so I think we have to have some honest conversations with those that are actually in these spaces and bring health system leadership, because part of this is we're putting our people, our trainees, into those kind of spaces. One last thing, and then I'm going to turn it over to Dale. We are having a call for individuals to join our EDIA Adaptive Mentorship Network. If you are looking for information about this, just scan the QR code or email us at eqhslab@briere.org for more information, and we'll be more than happy to get that to you. I'm going to turn it over to Dale for the last slide.
Well, thank you, Jerry, Stella, Cameron, Ritika, Sophia, and Vela. I think we could have had another hour with all of you, and we can just feel that the knowledge and experience that you have to share, and there's so much more that we could learn from all of you. I wanted to plug the next set of webinars. October 23rd, so coming up soon, we have one entitled From Hurting to Healing, Restorative Approaches to Advancing Equity and Justice. So recognizing within the workplace, there are often examples where the phobias and the isms and the structural structures have an impact on individuals. So what do we do when that occurs, and how do we move from hurting to healing? It's presented by Dr. Javid Sakura, and he's based at the Yale School of Medicine, and I really highly encourage you to attend. Also, we have a webinar November 15th called Considerations for Planning the Composition of Primary Care Teams Based on Community Needs. So taking a look at supply and demand when we think about planning for primary healthcare teams. So an important element in one of the team primary care projects led by Sarah Simkin. And then on December 8th, a webinar entitled Supporting Change Using Generative Approaches, and that's presented by Danny Nashman as part of the potential group. So I thank you all for attending, and again to the speakers and the panelists. I again would love to hear more from each of you. Thank you so much, and enjoy the rest of your afternoon. Much appreciated.